Hello and welcome from Lakewood Ranch. So this is the fourth video from our Member Skills Refresher session, and in this one we'll be looking again at medical and in particular looking at various treatments.
Before we continue with treatment, let's go back to the tourniquet option again. And that is, once a tourniquet is in place, then it's very important that we regard this thing as being a level red condition, even though the tourniquet is in place. Because now we want to get this person to a medical center in time to save either the arm or the leg that's affected. Remember, tourniquets are only applied to arms and legs, not to the body, not to the neck, in the event that you really feel that you want to do that. But anyway, at this point, if you can't get through on a 911, then we need to contact our IC, the group leader, and then the group leader will contact the hub, and the hub will get to EOC in the event that we need an ambulance to get somebody transported. Now, once we go through the, sorry?
We have a question. Can you confirm that you want to stop the pulse?
You absolutely want to stop the pulse, because downstream of where the tourniquet is, the pulse still indicates that we have blood flow. And the concern here is that with blood flow, we are going to be carrying toxins from that area back into the body cavity and actually cause a toxic shock condition with the heart. So both bleeding and distal pulse need to be stopped. Now we'll continue. Again, we stress the idea of protective equipment. Even though you've gone through the triage section and now we're getting into the treatment section, we still need to protect ourselves from fluids, aerosols, and it may be a more reasonable situation here. But one of the things that we really want to stress is that everybody wears their goggles on the top of their helmet. And they really don't do anything to protect you on top of your helmet. So the goggles need to be over your eyes, because in this environment, we need to protect hands, face, and eyes from both fluids and aerosols. When we start to get into the treatment area, we're going to do head-to-toe assessment. Now, this is best done if we have a conscious patient, but if we have an unconscious patient, we have to, first of all, make sure they are breathing. Secondly, figure that that unconscious state is based upon a head injury or a back injury, and so there could be spinal involvement. So we really want to be very, very careful on moving a patient that has this type of situation, or survivor, that has this kind of situation. The head-to-toe assessment allows us to assess the injuries and determine what kind of treatment's involved here. Start with the head, and what we're looking for is eyes that are not, pupil's not reactive. We're looking for any kind of fluid loss from the ears. Could be clear fluid, or it could be blood loss from the nose, indicating head injury or head concussion possibilities. As you move down, the collarbone is the most often broken bone in the body, and so you're checking for tenderness in the upper body by just pressing and asking and communicating with this survivor. Does this hurt? Do you have, is there a part that hurts more than anywhere else? As you move down, you're looking for pairs. In other words, you're determining whether one arm is different from the other. Is there any deformity that's obvious? You're asking the survivor, can you move your fingers? Can you move your arm? Is there any kind of numbness that is occurring in your arms or your hands? When you get down to the abdomen, this is where you're checking for tenderness, because this tenderness, as you press gently on the abdomen, is going to indicate any sort of internal injury that could indicate internal bleeding. Now you're moving down to the legs. You're checking for, again, you're looking at pairs, and you're checking for any kind of deformities or lack of movement, lack of pulse, and this sort of thing. Now, this is the other thing we talk about. We talk about PMS, and this is pulse, motion, and sensitivity. So at each one of the extremities, you're checking for pulses. You're checking for the capability of moving. And you're also, can you feel this? Can you do this? Can you press against my hand? This sort of thing. And also look for medical identification. Someone could be unconscious based upon perhaps a diabetic coma or based upon anaphylaxis. And so these are the kind of things that we have to take a look at. And as I say, once the frontal area is examined, Then what happens, you and your partner are going to work together because a partner needs to stabilize the head and neck. And we're going to turn the patient or the survivor on their side so that we can check the back. Now you've got your gloves on it all the time. And so constantly check your gloves to see if you're seeing any fluids, any bleeding, and that sort of thing. But this is a critical step in determining what the next step for treatment is going to be. Here's what we're looking for. The DCAP BTLS, DCAP BTLS. And most of these present very obvious. In other words, you can tell deformities, you can tell bruising, you can tell the abrasions and this sort of thing. The thing that you can't tell is tenderness. And so this is where you have to do a little bit of sampling. In many of these wounds, you are dealing with swelling that can be controlled by cold. And now, as I say, we have added cold packs to our team kits. And a cold pack is really a chemical pack that once you crush the cartridge on the inside and shake it, you'll have about 20 minutes of a ice pack type of device. Now, the ice pack may be too cold for direct application, so you might have to wrap it in an ace bandage or something like that to modify it for swelling and contusions and this sort of thing. The other things that you're looking at here are open wounds. And so now we're worried about cleanliness and infection prevention. When we're treating burns, the most important thing is to remember that the skin is the largest organ in the body. It's also the most important organ for preventing infection. In a first degree or second degree burn, we have redness or blistering of the skin. When we start getting into a third degree burn, we're actually seeing the skin layers deformed or consumed by the bleed or by the burning. Now, it's strange, but this morning on the news, I heard about a fourth degree burn, which was in an auto accident, and it was so severe the bones were actually burned. So in doing this, the most important thing is to remember that this is a source of infection, this openness, and we need to control the pain before we do anything else. The way we control pain is by cooling the area, usually by water, no ice. We're not going to put ice on this. We're not going to put our cold pack on this because it's a little bit too heavy for that. But we're going to cool by flushing it with water. And finally, after we get the pain under control and the area cooled, we're going to cover it with a sterile dressing and bandage, but a gentle bandage because pressure bandage is probably going to be very painful at this point. Now, there's something that's strange here because in treating burns, we can also induce hypothermia. And hypothermia is when we start dropping the temperature of the body, normally at 98.6, but by cooling too much of the body, we can actually reduce that body temperature approaching the 95 degree Fahrenheit range. And this is usually on small children or on older people. And by just simply cooling 15% of the body, which is about one arm, we can actually induce hypothermia. So we're looking for chills and that sort of thing. And the key thing is to get them warm back up. But prevention of infection after the cooling is our most important ingredient. All of these wounds, whether they're puncture wounds, laceration, so on, need to be properly treated so that we prevent infection. And the way we treat them is cleaning with room temperature water. Now you carry 1/2 liter bottle of water on your pack, but you got to remember water coming out of a garden hose is still clean water. And so we're never using hydrogen peroxide. We're not going to try to disinfect with that because that does more damage to the wound than it does good. We're not going to scrub it. We're just going to simply flush it and flush it and flush it and flush it some more. That's the key thing. We're going to apply a sterile dressing to the wound and bandage to hold it in place. Now, if there is active bleeding, we don't want to flush it because part of the clotting process is to remove water and allow the blood proteins to clot. And so in an active bleeding situation, we are going to redress over the existing dressing because the existing dressing is probably now part of the blood clot. So if we were to remove that dressing, we might start bleeding again. So after the bleeding is controlled, now we can clean the wound with irrigation. In other words, we're not scrubbing, we're just irrigating with clean water and redress it and bandage it. Now, after we have these wounds cleaned, dressed, and so on, we need to check every 4 to 6 hours to prevent infection. Now, we're looking for infection if we get heavy redness around the wound, or if we get red striations that look like they're moving up the arm or up the leg. In this case, we want to make sure that they get the medical attention to control that. It's not a matter of putting on a multiple antibiotic in the field. Impaled objects are a different thing. Impaled objects are the puncture wound that we were talking about with arterial bleeding. And so that puncture has possibly got a part that has, interfered with an artery and perhaps is causing the artery not to bleed because of its actual impact point. So in the case of an impaled object, we are stabilizing the part of the body, and we're making sure that that impaled object does not move. So we're bandaging around it, but leaving it in place, controlling the bleeding at the entrance to the wound. Now, in the essential where we're impaled object in the eye, and this is a pretty difficult thing to even think about, but first of all, we have to stabilize that object where it is in the eye, bandage around it, and then we have to cover the other eye because eyes move together and we don't want any eye movement at all. When we have fractures in the field, it's very difficult to determine unless it's an open fracture. Obviously, an open fracture, we see the bone protruding through the skin, and we probably have a bleeding event as well. Closed fractures are only indicated by pain and swelling, but can only be diagnosed with an X-ray when you finally get into a medical center. If we have a closed fracture that is not displaced, again, very difficult to determine, but if a displaced fracture is going to show a deformity in that arm or that leg, and it depends on where it is. If it's very close to the joint, it could well be a dislocation rather than a displaced fracture. In all these situations, the way we treat them is to immobilize, and that's usually splinting, but it could be other situations that we'll go into later. In the case of an open fracture, we are not going to try to put that bone back into place. We are not going to irrigate that wound because we can actually put material back into the wound that was going to be detrimental. We're going to cover the wound with a sterile dressing and splint it without disturbing the wound. Now, this is a very difficult thing because it's going to be very painful for the survivor at this point. And then the other thing is we want to keep a moist, sterile dressing over the end of the bone because we don't want that to dry out. Dislocations are different from fractures in that what we have done now is stretch the ligaments holding the bone to the joint to the point where the bone is dislocated from the joint. In a sprain, we have that ligament damage done, but we have not displaced the bone from the joint. In both these situations, we have a situation where a lot of pain and lack of structure or lack of strength. And so they need to be supported. And before any support is done, we need to check this pulse, movement, and sensation to make sure that blood vessels and nerves have not been affected in this dislocation or sprain. When we start talking about splinting, in our backpacks, we carry an 18-inch SAM splint. Now, this is called a junior splint, and it's an easily fashioned or molded splint that can go around an arm or mostly an arm. In this situation, make sure that you mold it around your own arm before you put it around the survivor's arm, because it will be a very painful situation for someone with a fracture. In the team kits, we also have 36-inch SAM splints, which are probably best used for legs and so on. If you don't have a SAM splint, cardboard, wood, newspaper, towels, anything that can add structure on the joints above and below the fracture or dislocation can be used. In the case of, let's say, a sprained ankle, we want to make sure we don't remove the shoe or the boot because that'll induce the swelling that's going to happen. Splinting guidelines are as follows. We want to support the injured area above and below the injury. So it's top joint to bottom joint. We're going to assess the PMS before and after the splinting. We're going to splint the injury in position, and we're not trying to realign bones or joints or anything like that. Now, we want to immobilize this area. And the way we can do that is, first of all, we have triangular bandages that can be formed into a sling. We want to support the arm, and the best thing to do is just ask the survivor, where is this comfortable when you're setting up an arm splint or an arm sling like that. In the extreme situation, we might be tying 2 or 3, try and get our bandages together to tie the appendage directly to the body, supporting it that way. In the extreme situation, we may be using duct tape to immobilize that appendage to the body in order to make sure it's comfortable and movable. Now, we live in Florida, and so heat exhaustion and heat stroke are always the possibility. And this is not just for the survivor, this is for the volunteer. Every volunteer, CERT volunteer, is equipped with a hydration pack. Now, this hydration pack has a bladder that's 1.8 to 2 liters in volume and can be filled with water or sport drink, to support you during your mission. Best not to use caffeinated beverages or alcohol because they both act as diuretics and actually remove fluids from the body. The key point here is don't wait until you're thirsty to drink. Maintain your hydration because now you've got probably a lot of support equipment on. You're carrying a medical bag and this sort of thing, or your medical pack. So there's a possibility of really dehydration for the CERT volunteer as well as the survivor. When we have heat exhaustion and compare it to heat stroke, the primary thing we look for is sweating. The body's method of heat transfer is by evaporation of sweat from the surface. And so in heat exhaustion, heavy sweating, the body is still controlling its temperature by sweating heavily. We probably have pale or flushed skin. The person could be dizzy, nauseous, and quite exhausted. When we finally lose that ability to control the body temperature by perspiration, then we start getting into heat stroke. And this is a very, very difficult situation because now the body temperature, instead of being 98.6, is starting to rise into the fever point of 103. And when it approaches 105, then damage can really be done. And this could be a life-threatening situation. It presents very much like shock because we have a weak and rapid pulse, shallow breathing, these kind of things. The most important thing is to remove them from the heat and into a cool environment. If we can't get into air conditioning, at least get into shade, and we want to cool the body slowly. We don't want to shock it. However, I was told by a paramedic one time in a heat stroke patient to actually get him into the water to get that body temperature down. I think probably one of our best approaches is to use our cold packs that we have in the team kits right now. And again, the cold pack needs to be activated before it works. You need to break the cartridge on the inside and shake the contents to get it cold. And then it's best to apply it either to the back of the neck, into the armpits, or the groin. And there are multiple, so we can use multiple packs if we need to. But in those areas, that's where the blood flow is closest to the skin and most amenable to being cooled. We're not going to provide a lot of water to these people because they're going to be throwing up. So drink water slowly, and it doesn't have to be ice water. It can be just room temperature water. All we have, it's not going to be very palatable, but it's still going to get the body fluids so that sweating can occur and the body can start controlling its own temperature. If there's loss of consciousness, then we really have to start thinking about getting this person to a medical center. Now, in summary, these are the kind of steps that we can take. In triage, we're going to go control airways, bleeding, and manage shock. In the final treatment steps, we now have our first aid capabilities, so they're going to manage the others, the burns, the wounds, the amputations, amputation by actually using tourniquet, and then the heat-related injuries. And cold-related injuries we think of as being something that happens in the north. Please keep in mind that you can get hypothermia in 70-degree water very quickly. So even if somebody goes overboard in the Gulf, when it's not 90 degrees, they have the possibility of getting into a hypothermia situation in which we need to gradually warm the body. Now, do we have questions?
Pat, yes. Gerald Moore had a question regarding tourniquets. It's
yes.
Multi-part. Is a tourniquet only used on arterial bleeds?
Yes.
If so, wouldn't it be most likely we would be on scene before a person had bled out? With serious venous bleed that requires pressure, should a team member stay with the patient until a first responder arrives?
In the case of a venous bleed, it is probably best to have a volunteer stay because we want to keep our teams moving for the triage thing. So we can leave them with supplies, with a volunteer, and what you're really doing is applying pressure and that sort of thing. The venous bleed is not the critical bleed that requires a tourniquet. Was there another section of that I missed?
Yes.
His question was also, is it pretty unlikely that we'll be first on the scene if someone's got an arterial bleed?
I was told by a paramedic one time, unless you're there when the arterial bleed occurs, you're going to find them dead. So the answer to that is, in all likelihood, they will bleed out before we find them. And that's one of the reasons we have to keep moving, because we have that golden 5 minutes on airways and arterial bleeding that are very, very critical.
Thank you, Pat.
Mm-hmm.